morning, good afternoon, good evening, good night. Thanks to each of you for being here with us today to make this event possible. We trust that the meet sessions from the previous chapter have been of interest and have contributed meaningfully to your professional development. I am Professor Maxine Gossel-Williams from the University of the West Indies and Special Projects Coordinator for the North American chapter of ISoP. I bring greetings on behalf of ISoP. We are delighted to be hosting this session as part of Patient Safety Day activities in collaboration with the Special Interest Group Pharmacovigilance in the Community. Since its inception in 2013, the NASOP chapter has strived to promote pharmacovigilance through educational and professional training initiatives and fostering partnerships with other organizations with similar interests. Our membership now stands at 226, who we regularly engage with monthly meetings. NASOP prides itself as a chapter that facilitates the engagement of all members through our working group initiatives and our annual meetings. One group of special mention is the American Pharmacovigilance and Pharmacoepidemiology Curriculum, AM2P group. Through this group, we now offer educational components specifically tailored for North America. Please visit the ISoP website for more information about our activities, including our annual meeting to be held December 3rd, 2025. I also invite all the attendees in this session to join our LinkedIn platform where we share information on patient safety. The theme for the conference, Safe Care for Every Newborn and Every Child, is very timely. The presentations of day one were insightful in highlighting the urgent need to focus on risk minimizing interventions to protect this inadequately understood population, often inappropriately referred to as mini adults. Joining me is Rebecca Noss, a global expert in pharmacovigilance across both pre- and post-marketing contexts. With a strong medical foundation and 28 years of experience in the pharmaceutical sector, Rebecca holds an MSc in pharmacovigilance and pharmacoepidemiology from the University of Bordeaux and is an active member of ISoP. She also leads the Special Interest Group Pharmacovigilance in the Community, which is dedicated to enhancing patient safety and reducing emergency room visits due to adverse drug reactions. This is achieved by educating pharmacists and healthcare providers on pharmacovigilance practices and empowering them to effectively guide patients in the safe use of their medication. Rebecca, thank you for joining us today, and I hand over to you.
Thank you so much, Maxine. I appreciate the opportunity to co-host with you. On behalf of ISoP, we are very pleased to welcome all of you to the 6th edition of the Patient Safety Day event that was held yesterday and then today, the 19th. The World Health Organization has designated September 17th as World Patient Safety Day to enhance public engagement in health, safety, and to promote global actions aimed at preventing and reducing harm associated with healthcare delivery. This year, the WHO chose Safe Care for Every Newborn and Every Child under the slogan Patient Safety from the Start, meaning this age group risks and harms that result from unsafe care. ISoP reaffirms the objectives of the WHO Global Patient Safety Challenge and calls on stakeholders and healthcare professionals to prioritize and take early action in critical areas associated with significant harm in pediatrics and neonatal patients due to unsafe medication practices. Starting, our president, Dr. Angela Caro, will address a few words to all of you, so please listen carefully.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
Alina is a specialist in pharmacovigilance and regulatory affairs with 18 years of experience in pharmaceuticals, including more than 10 years as a global consultant for marketing authorization holders, CROs, and distributors. Alina's work includes regulatory submissions and pharmacovigilance oversight in the Middle East, North Africa, South Africa, the European Union, Latin America, as well, and the Commonwealth of Independent States that cover both pre and post-marketing. Alina is a very experienced auditor in good practices, and her experience includes, again, the Middle East and North Africa, independent states, Latin America, and the European Union. We invite you to participate in this session actively. So please, if you have any questions, put them in the chat box and we will respond after we're done with the presentations. We welcome you, Alina. The floor is yours.
Thank you very much, Rebecca. Good morning, good evening, good afternoon, everyone. Thank you very much for joining today for this, I can't say otherwise, a very important topic. And thank you very much, Rebecca, for your lovely introduction. So my topic today will be about introduction into pediatric pharmacovigilance and current gaps and challenges. So I'll begin with an introduction to pediatric pharmacovigilance and why children are just, and I'm just small adults. Sorry, it's about me, but we can skip for sure. So I'll begin with the introduction to pediatric pharmacovigilance and why children aren't just small adults. Then we'll look at what makes pediatric safety unique, the main gaps and challenges, and some real-world examples, both failures and successes. So I'll finish by looking ahead and closing with a short summary. So now that we have set the agenda, let's begin with a simple question. What exactly do we mean by pharmacovigilance in children? And let me start with a boring but important definition. So pharmacovigilance is a science and a set of activities focused on monitoring, detecting, preventing adverse drug reactions in children. It is distinct from adult pharmacovigilance because children differ in many ways. Their physiology, development, and behavior make their responses to medicine less predictable and sometimes very different. So that's why effective pediatric pharmacovigilance is so important. It ensures that the medicines we use for newborns, infants, children, adolescents are not just based on extrapolation from adult data, but supported by real evidence. So to really understand why pediatric pharmacovigilance matters today, we need to look back a little bit at the history. So in 1937, the sulfanilamide tragedy killed 107 people, most of them children, after a toxic solvent was used in a new liquid antibiotic. So this led to the Food, Drug, and Cosmetic Act of 1938, one of the first laws requiring proof of drug safety. A few decades later, unfortunately, we had another tragedy I'm sure most of you are aware of, the thalidomide disaster that caused thousands of birth defects, leading to stronger global safety laws and the foundation of modern pharmacovigilance. But there was also an unintended consequence. Children were excluded from most clinical trials and became therapeutic orphans. So many treatments for them were off-label with little safety or efficacy data. From the 1990s onwards, reforms began to change this. The US introduced the Best Pharmaceuticals for Children Act, and in Europe, the 2007 pediatric regulation made pediatric investigation plans, PIP, mandatory for new medicines. These steps created the framework that we use today. So now let's have a look why pediatric pharmacovigilance is so unique. Children, as I said, are not just small adults. Their bodies, their development, and even their psychology make them very different from adult patients. So physiologically, their organs are still developing, which changes how drugs are absorbed and cleared. Anatomically, their body's composition, more water, less fat, affects drug distribution. Cognitively, they might not be able to describe what they're feeling, so adverse reactions can be missed. And psychologically, children may resist treatment or stop it altogether, which adds another level of complexity of monitoring. So data shows us how important this is. For example, retrospective studies have found that children under 2 years old have the highest incidence of adverse drug reactions, up to 40%. And when we look at global pharmacovigilance databases like Vigibase, for example, between 2010 and 2019, there were more than 1,500 fatal adverse events reported in children, and most of them under 2 years of age. So now that we talked about why children need special attention, let's look at what pediatric pharmacovigilance actually does to keep them safe. Its purpose is to turn real-world experience into safer care. So first, we collect and analyze safety data specific to children, not just spontaneous reports, but also from trials, hospitals, records, registries, and the literature. We separate the age groups, newborns, infants, children, adolescents, because the same medicine can behave very different as the child grows. Second, we develop risk management strategy tailored to age. This can mean tools like weight-based dosing calculators, or maybe switching to child-friendly formulations. Third, we track age-related patterns of adverse events. Why? For example, in neonates, immature metabolism can cause toxicity. In toddlers, dosing errors and hypersensitivity are very common. In adolescents, adherence and CNS active drugs require special focus. So the aim is to spot risks early and act before harm spreads. And finally, pediatric PV supports regulatory decisions through pediatric investigation plans in Europe or written requests in the US. So let's take a look at how medicines are actually used in children today. First, off-label and unlicensed prescribing is still quite common in pediatrics. In some hospital settings, more than half of prescriptions fall into this category. To address this, we're seeing more use of age-appropriate formulations, liquids, dispersible tablets, or even mini tablets. This is great, but they are not always available. So when no pediatric form exists, adult tablets are often split or crushed to make smaller dose. This is risky because it can lead to inaccurate dosing, especially in the youngest and most vulnerable population. So care for children is also very multidisciplinary. Pediatricians are involved, pharmacists, nurses, caregivers, parents, and they all play a role in prescribing, preparing, administering, monitoring what's being taken. Each perspective helps reduce errors on the way. And finally, we have electronic health records now and adverse event reporting systems that are used more and more often. So while current practices show progress, there are still clear challenges that make pediatric pharmacovigilance especially demanding. So one major issue is the continued practice of breaking or crushing adult tablets with no pediatric form exist. This leads to inaccurate dosing and unpredictable exposure. So even when dosing is weight-based, small calculation errors can lead to big consequences. So recognizing ADRs is another challenge in young children, and I'm sure pretty much like in adults. Common symptoms like, I don't know, let's say fever or vomiting reflect the illness itself, or it can be drug-related, and it's hard to tell the difference. So we also face a serious lack of trial data, particularly for neonates and rare diseases. This makes dosing decisions difficult and often uncertain. Underreporting is still a problem, although with the raising awareness, it still exists. Children cannot always describe also what they feel, and caregivers or clinicians may not connect the symptoms to the medication. So hospital environments add another layer of risk. For example, a recent study in pediatric surgery found adverse event occurrence in about 1 in 4 patients, often due to drug-drug interaction. And across all these challenges, medication errors stands out. Prescribing or administration errors affect up to 15 to 20% of prescriptions and are among the leading causes of ADR-related hospital admissions, also including children. So while medication errors are part of the broader challenge, they also contribute to safety concerns in pediatric population. Let's have a look at 3 real-life examples very quickly. So based on what I have presented so far, these real-world examples show how pediatric pharmacovigilance have made a shift, how evidence monitoring and smart interventions have improved outcome. For example, for HIV therapy in children in 1990, antiretrovirals were tested mainly in adults, and dosing was extrapolated to children, and often causing toxicity or poor results. With pediatric trials and safety monitoring, child-friendly syrups and dispersible tablets were developed, along with weight-based calculator, and that improved survival and quality of life for children with HIV. For vaccine, there is an interesting example of rotavirus. So early use raised concerns about interception, a rare bowel obstruction, and pharmacovigilance confirmed a small increased risk, only about 6 extra cases per 100,000 infants, but also showed the benefits that actually outweighed the risks. So together, rotavirus help prevent millions of hospitalizations and death. Another successful story comes from oncology with the drug imatinib. In this study, researchers built a physiologically based PK model for imatinib in children aged 2 to 18 years. They considered how the body matures, enzyme activity, body weight, and co-medication potentially. So the model showed the optimal dose for many children was about much lower per day than the dose simply scaled down from the adult dose. So it also highlighted that drug interactions affecting CYP3A4 enzyme could significantly change imatinib levels. So with this tailored dosing, imatinib was well tolerated and toxicity was reduced and children achieved good progression-free survival. My third example, final one, I'd like to shift focus from individual medicines to pharmacovigilance, to how pharmacovigilance works in practice as the system. So between 2021 and 2023, a study in Italy followed children receiving cancer treatment. Active pharmacovigilance team, which included pediatricians, pharmacists, nurses, of course, and pharmacologists, monitors the cases closely. So they found serious adverse reactions were almost 3.5 times higher, more common with off-label prescribing, and nearly 200 severe cases were detected, along with several near-miss errors. So the key result is that by working as a team, they could detect, report, and manage these reactions far more effectively. So as we look ahead, several priorities stand out for pediatric pharmacovigilance. We already see stronger use of real-world evidence, electronic healthcare records, registries to fill the gaps left by small clinical pediatric trials. AI and big data tools are starting to support early signal detection and help identify children most at risk. So this is still new, but pilot projects are rather promising. A more patient and caregiver-centric approach is also important, and I think it's getting more and more popular. We all talk about it. So involving families directly in reporting can make safety monitoring more complete and practical. And on regulatory side, I know there was a recent guideline, ICH 11A, which was finalized last year. This is a new global guideline that explains how and when data from adults or older children can be safely extrapolated to younger children. So the goal is to speed up access to medicines for kids while still collecting, enough safety data that we need, especially in vulnerable groups like children. Globally, of course, closer collaboration between regulators would be needed to close the gaps in the fragmented approaches. We also need more focus on special populations such as neonates and children with rare diseases, because there the data is still scarce. And finally, we must strengthen a culture of safe medicine use, not just in hospitals, but for example, in schools and homes. So simple things like accurate dosing, correct administration, altogether avoidance of unnecessary drugs can make a real difference in the everyday safety of children. So to conclude, I want to emphasize one simple but important message. Ensuring safe care for every newborn and every child is a responsibility we all share, regardless we are regulators, healthcare professionals, industries, or families. And we've seen how progress has been already made, but I'm sure there's still some work to do. So with this, thank you very much for your attention, and I'll now hand over to the next speakers.
Thank you so much, Alina. This was a fantastic topic. And again, the audience, please put your questions in the chat and we'll answer those after the presenters are finished. Now, let me introduce to you two speakers from the European Medicines Agency, Dr. Roberto De Lisa and Dr. Cosimo. Dr. Cosimo is a signal management lead at the European Medicines Agency and co-chair of the PrAC Smart Working Group, responsible for the review and testing of new tools for signal detection with a focus on pharmacovigilance in pregnancy and pediatrics. During the recent pandemic, he also coordinated the EMA's COVID-19 vaccine safety group. Dr. Roberto De Lisa holds a medical degree from the University of Cagliari in Sardinia and specializes in pediatrics medicines development, including clinical pharmacology and a master's in pharmacoeconomics. Since joining the European Medicines Agency in 2006 and the Pediatrics Office, Dr. Roberto has focused on the scientific assessment of potentially inappropriate prescribing and focusing on antivirals and migraine, as well as modeling and simulation, pediatrics, pharmacovigilance, and real-world evidence. Welcome. The floor is yours.
Thank you so much, Maxine. Thank you so much, Rebecca, for introducing us and for inviting us to speak about this important subject. You would see that many of the topics and many of the slides would actually partially overlap with some key concepts that Alina already introduced us, and I thank her for a very comprehensive presentation. But I'm sure you would not mind, because those, in fact, are the key aspects that needs to be emphasized when conducting pediatric pharmacovigilance. I trust you can see the screen now. Can you see the slides?
Yes, we can.
Yes, that's very good.
Yes.
I will share this presentation with my colleague Cosimo, of course. So just a quick disclaimer to say that we are representing, of course, in this presentation our view, and this should not be taken as the view of the EMEA, intending as an institutional view. What is important and what is the population of children in the EU? Well, in many member states, unfortunately, it's concerning that the estimates for 2050, it's actually decreasing the natality is decreasing compared to the previous year. But still, now nowadays, around 18% of the population in Europe is composed by pediatric patients. When we talk about pediatric age groups, of course, we talk about a universe on its own. So we're talking about newborns from birth to 1 month, and we will see also that there's the issue about preterm newborns that actually are actively treated in intensive care units who also experience adverse drug reactions. Then we have infants from 1 month to 2 years that are susceptible to adverse drug reaction due to immaturity of some of the metabolism systems. Then we have children from 2 to 12 years of age that they also have need for those adjustments, and adolescents that, although for some aspects can be assimilated to adults, they have all their own specificity and susceptibility to different adverse drug reaction. First of all, the problem with pharmacovigilance and for safe use in pediatrics has always been the dose, but recently this problem has been more or less overcome with new indication and new studies that have targeted the pediatric population. We have touched upon also in the previous presentation about the adverse reaction that affect children across different environments. Especially, of course, hospital admissions. Adverse drug reaction can be a cause of hospital admission. So a reaction to a drug must always be kept in mind when there is something that is not explained and is not justified by another diagnosis. Then we have reactions that are actually happening during the hospital stay of children, so in hospitalized children, which prolong the burden of the hospitalization and sometimes the timing the children are spending in hospital. We will see in this case sometimes hypersensitivity reaction are responsible for a lot of this. Then, of course, reactions in the community settings, and in the general population, we can say that the literature is a little bit newer and fresher compared to adults, but we can say that ranges from 1% to 9%. So the first thing to do in pediatric pharmacovigilance, but also in adult pharmacovigilance, is to know, then to recognize, and also to share this information. How do we grow our knowledge about the safety profile of a medicine in pediatric population? Well, you know, and it has been highlighted before, in the US and in EU, we have specific law enforcement measures to agree what is going to be the pediatric development of a medicine before it reaches the market. In Europe, this is contained in the so-called pediatric investigation plan. Importantly, in this plan, we have plans to conduct non-clinical studies that involve juvenile animals in a way, so adding knowledge on the ontogeny of the medicine. Then we have the study and the mandatory requirement to have an age-appropriate formulation development, and this itself has also diminished improved safety, diminished adverse reaction and improved safety in children. Then we also have in the pediatric investigation plan the list of all the studies. Once this pediatric investigation plan is completed, of course, we have a basis to arrive at the marketing authorization that, of course, for some pediatric diseases, you know, it cannot come soon enough because fortunately, the pediatric population is an healthy one, but still there are many diseases that are congenital or hereditary. We have severe cancer that can undermine, of course, the life expectancy, and we have other diseases that are rather orphan that manifest in the pediatric population. So we arrive at the marketing authorization, but the story, of course, doesn't finish there. There are specific measures that needs to be in place, as well as in adults, to ensure that use is safer. I will give the floor for this slide, particularly to Cosimo, because he can give you an insight of what we know at the time of the authorization and what is it that we don't know. Cosimo?
Yes. Thank you, Roberto. And indeed, this is a slide just to represent what we already mentioned. It was already mentioned by you and by Alina, that the incidence and the prevalence in real-world settings are critical, as they determine how likely it is to actually observe an adverse event. Now, this is what is essential for us in pharmacovigilance because that is what drives our monitoring strategy. So at the time of the authorization, clinical trials, the gold standards, of course, they give us a very robust evidence on the efficacy, on the quality, and on the safety, on the most common adverse drug reactions. However, gaps remain for patients with which have special condition or they're actually excluded from the trials. So we often do not know the long-term effects, the drug-drug interaction already mentioned, the off-label use, medication error, but most importantly, and that's what illustrates the little table on the right-hand side, is that to be able to capture or detect the rare, very rare event, this is very challenging, and we need post-marketing data. In fact, to reduce the chance of missing a very rare events to only 5%, we would need data from about 30,000 patients. And if the trial only includes 500 patients, as it always happens, particularly in a rare disease, the chance of missing a rare event rises to 95%. So as you can understand, yes, the clinical trials are very fundamental for the establishment of the safety of a medicinal product, but the post-marketing data will be essential for the establishment of the full safety profile. Over to you.
Thanks, Cosimo. Let's go back a little bit before we go back. We go and see what is done in the post-authorization phase. How this has been developed in Europe. We said like we had the pediatric regulations of specific law to have a dedicated development in pediatric patients, but already at the time in 2007 there was a concept that the pharmacovigilance was also to be conducted for the pediatric population with some special attention. Then also Alina mentioned the reflection paper on the user extrapolation in medicine development that throw the basis also on what we can understand from adult data and which kind of data can inform the use in pediatric patients, until we have in 2018 we have adopted a special guideline for the conduct of pharmacovigilance in the pediatric population. Now, the measures that are included there, they are not radically different from those from adults, but there are some specificities and some specific aspects that are highlighted there. Another aspect that I wanted to draw your attention to is that since 2013, we have seen, and I thank my colleague Kateri Zhang for this research, Stephanie Zhang for this research. Since 2013, we have seen a massive growth of all the pediatric indications in the EU. This means that all the pharmacovigilance activities are going to be multiplied, and there will be more and more pediatric medicines on which to do signal detection, on which to do safety authorization studies, or to examine and assess what are they called the pediatric safety, the post-authorization safety reports. As I said, the pediatric pharmacovigilance guideline has some aspect that concern like the age-specific monitoring, on which Cosimo will spend some slide to give you an idea of what we do in-house on those reports that arrive to that are a signal to the European Medicines Agency. There are some consideration for off-label use and unlicensed drug use. There are some consideration for active surveillance on the design of post-authorization studies that are effective for children. There are also some consideration regarding formulation challenges and excipients, and how to take this into account in the assessment in pharmacovigilance, and particularly also which kind of medicines and for which effects long-term monitoring is effectively needed, because there is a delayed risk of adverse drug reactions. Pediatric off-label use is extremely common, especially for medication that have been authorized long ago. of course, is not a bad thing on itself, but we have to recognize that it can be linked to a risk of increased adverse drug reaction. Why? Because we don't know sometimes entirely the profile, although for these medicines that have been authorized in the past, the amount of knowledge now is quite substantial. Because there could be dosing errors, because generally for these medicines, they did not have a specific or studied, they didn't study the exact dose to be dosed in children, but were derived from adults. Although here I will open like some additional consideration saying that use the modeling and simulation now is helping us also in resolving this. And I will go also to stress the fact that the pediatric development plans, and it's a concept that Alina already introduced, the pediatric pharmacovigilance is more like a circle of knowledge, like where we start with the developments, then with this development puts the basis for an effective risk minimization plan. Once the medicine is used, it is on the market, we have the post-authorization safety reports that inform us on how the use is going what are the use, what is the uptake, what is the utilization, and what could be the suspected safety signals that are connected to the use in pediatric population. For pediatric patients, for example, in the RMP, we listed some concerns that need to be taken into account, particularly in development. So effect, of course, any drug that has an effect on growth, on bones, on sexual or neurobehavioral development needs to be studied specifically. And these aspects need to be particularly elucidated during development with appropriate evaluation. For neonates and toddlers, again, we need to have particular monitoring and the preambles to have a safe use given the immaturity of some systems. And again, the excipients are thoroughly evaluated when a formulation is proposed based on precedents to ensure that they are safe and they are not concerning for use in pediatrics. We have, for example, at the European Medicines, a formulation expert group that revises all the formulations that are proposed, not only to see that they are like, that there is no waste of medicines, that the doses minimize the risk of any errors, but also that the excipients are the most appropriate ones. We already, Alina also touched upon Rotarix, and I'm happy for that because it was an important achievement of pediatric pharmacovigilance. And nowadays, based on results of very significant studies, we have ensured the safer use, and especially we have on the market safer product to decrease the risk of infection by rotavirus. That I would remember in some countries is a case of morbidity that is very, very high, with diarrhea that can even have a fatal outcome in some settings. More recently, during the pandemic, there was another topic that was really prominent in the media. For example, tocilizumab, the Comirnaty vaccine. There was supposed to be an increase in risk of myocarditis. Now the EMA has launched a study that is currently ongoing, has provided some interim results. But again, just to say that how pharmacovigilance has evolved and how tailored studies are conducted in the pediatric population. There is a group also of the International Neonatal Consortium that are now focusing on specific tools to standardize the assessment of severity in the neonatal setting. In the neonatal setting, and because of course the neonates they cannot express sometimes what is the adverse effect for that is where they are involved. So they either sleep more, they eat less, they cry. But in this way, we can standardize and we can have a more homogeneous reporting of any reaction that is also recorded in the neonatal setting. Other emerging topics, also Alina mentioned the role of real-world evidence is also a tool that we are using more and more at the European Medicine Agency, the role of precision medicine, and the issue of communication, because communication of safe use in the pediatric population is a topic on its own. You know, we need to address specifically the communication need, for example, of adolescents. We need to involve children in the understanding of the medicines that they are taking, and possibility that they have to understand what it could be an adverse reaction. We need to involve the carers and the parents also in this framework. And with this, I will give the floor to Cosimo that will tell you more about collection and correct identification of signals.
Thank you, Roberto. And indeed, after your overview of all the activities focused on pediatrics, and the prominent, let's say, in terms of detecting new safety concern is the monitoring of post-marketing data. And this is, of course, essential because it is actually collected, it's reported by both the healthcare professional and the patients and themselves to the national competent authorities or the marketing authorization holders. At that level already, we often talked about underreporting, however, in pediatrics. However, we should also talk about the quality of reporting, because most of the signal could be already identified based on the available information in good report, which is expressing specific details and matrix for the establishing causal link between a drug and an event. At that level already, because the process is already well, let's say, guided through the specific GVP and specific reporting rules, some details on the quality of the reports could be facilitated, we hope in the future, even with processing using also AI and collection of data at different levels. Now, another thing that we need to say is that we receive this large amount of information, not only for pediatrics, into the Eutrovigilance system, which is the European system for collecting, managing, and analyzing adverse drug reactions. And we screen them all based on priorities, but we screen them at the level of a drug and on the event. However, without a specific stratification by age and characteristic of the patients, we wouldn't be able to be focused on detect signals in pediatrics. Next slide, please, Roberto. So this stratification is at the level of the ICH, and nonetheless, we are able to identify specific subgroup within the total population. As I mentioned, there are specific priorities we apply based on the likelihood that the reactions is linked or potentially linked to drug use, based on the mechanism of actions, on the previous knowledge of the drug itself. So during the screening of spontaneous data, the intensive screening is across all age groups, and this is for designated medical events. However, for more common events that are like multifactorial in etiology or may be confounded by the disease itself, we rely more or mostly on the statistics, in particular on the frequency of reporting. And as far as the pediatrics are concerned, we try to ascertain an imbalance between pediatrics and the rest of the population. And of course, we also monitor the literature in order on a weekly basis. That is just to ensure that our understanding of the drug safety profile continues to evolve in real time. So next slide, please. And this is more focused on the special population and special situation. If you could move to the next slide, Roberto, please. Yeah, I think there is I think it's animation. Yeah, we move on. We didn't.
Okay.
Yeah, here we go. I think you need to go for the full slide. Sorry, these were not removed previously. Yes, so this is a very short. No, go backwards now. I mean, we don't need the slide neither. It's just to say previously what we focus on the terms that are likely to be related in pediatrics, and this list of targeted medical events in pediatrics is really focused on some outcomes or reactions actually that could easily link to a very serious or fatal outcome in pediatrics. So we actually rank them and we closely monitor because we know they are more frequently reported with this serious outcome. While on the statistics side, we rely on reporting of thresholds. And as I said, we have specific thresholds to take into account the underreporting in pediatrics, but also difference in frequency between adults, elderly, and pediatrics. Next slide, please. So now moving to a specific focus or topic where actually this is the general trend where we monitor a specific drug, but when we move to specific contexts such as pandemics or vaccination, then we need to take into account additional tools, additional methodology, and the observed to expected analysis actually what we use for enhancing the monitoring strategy. Here is basically a comparison between the cases that we observe spontaneously, and we compare them with the cases we would expect based on the background incidence rate and the exposure data of the vaccines within a specific risk windows. Now, if there is an imbalance, then we try to contextualize the data based on, we try to match the case definition, we compare with the electronic records, as I said, with the coverage data when available in a specific risk window. But this wouldn't be sufficient, yet again, if we couldn't have all the information at the level of the age and gender subgroups. So we need to stratify each of these data, observe the expected, the background incidence rate, and the coverage at the level of each age group in order to differentiate the imbalance and understand the excess risk in these populations. Next slide, please. And we are nearly there. Next click. So here it's just to show how dashboarding also are taken into account or built whenever we need to have a strategy to monitor data over time. And now they allow us to visualize how cases are distributed in pediatrics versus the whole population. And we also track how the risk is changing over time if we implement some sort of risk minimization measure. And we want to, or we expect that there is a reduction of the number of cases received. Next slide, please. Yes, I wanted also to flag a few cases, a few signals that have been triggered using spontaneous reports. And I'd like to start with the levetiracetam, the dosing error in children. This was a specific signal which we traced down to the dispensing mistakes and the incorrect use of syringes. And this actually was causing overdose in children because of the misplaced or the misuse of the syringes. And this has led them to actually perform readability studies for the parents and a revision of the product information, both improving the color codes of the packaging, but also using for the first time pictograms to identify different age groups. And that would be actually a risk minimization measure to reduce the risk of dispensing mistakes. Another important example is the fentanyl patches, transdermal patches, which led to accidental exposure in children, signals initially detected by FDA, because it was traced down basically to the root cause was either the poor disposal of the patches or even patch transfers from parents to children, and actually tragically led to some fatal cases. This has prompted actually stronger visibility measure for the patches themselves to avoid this issue. And last but not least, but it's what already Roberto mentioned, is the very popular signal with myocarditis and pericarditis. This, I mention it here just to say that we could identify the signal based on the observed to expected analysis. However, it takes more real-world data evidence or epidemiological studies that came later to measure the excess risk in this population in young men at that time. And actually, with the ongoing studies, we try to elucidate even more the mechanism of actions and reduce the risk as much as possible. Now, moving on to my conclusion, I would just say in the last slide that yes, so we try to collect as much as possible the available evidence. Sometimes we need to generate rapid evidence as I explained during mass vaccination, but we always keep the focus to children and to the different subgroup population, not only children, but the vulnerable. And the pharmacovigilance techniques will change according to the age group because of their peculiarities. Pregnancy is another one, and breastfeeding and even more. So I would say that clinical trials are very important, and particularly in children and perhaps also in pregnancy in the future. Or there are some studies occurring in pregnancy, and the correct data stratification is essential for actually stratify the risk and characterize it. I would say also, I should mention here that AI will play an important role in addressing unique challenges to children and in general to the vulnerable population, as not only improving the quality of report, but also fast identification of specific trends in specific groups, so that we can ensure safe treatment, especially for the most vulnerable. And that's a very good example where we keep monitoring, and that's what transforms data into public health protections. And I'll stop here for any question. Thank you very much for your attention.
Thank you so much, Dr. Cosimo and Roberto. It was excellent. Excellent. Now I would like to introduce Dr. Siva. He's going to join you guys as part of the panelists. And then we'll go over a couple questions and then see if the audience, posted any in the chat box. Dr. Siva is a physician and he works as a global safety director at a large pharmaceutical company, has extensive experience in AI, in safety automation, signal and risk management, and end-to-end PV operations. So I'll go ahead and start with the questions. So if you don't mind, Alina, you'll be first. In pediatric pharmacovigilance, we often talk about neonates, infants, and children and adolescents. From your perspective, which of these groups presents the most unique safety challenges?
That's a good question. I would say if we talk about different groups, so the toddlers, of course, they are growing kids, and everything is changing very quickly for them. So they will be challenging. They refuse to take medicine sometimes, but it's manageable. For adolescents, it's it was mentioned in the previous presentation. It was they are more or less closer to adults, but I think for the infants, for the newborns, this is very, very challenging population. So they have immature organs, they have rapid changes, they have limited communication, of course, and tiny sample size. And if we go even further and talk about premature babies, I worked in one of clinical trials with premature babies. They even add the complication of actually additional conditions, like, let's say, respiratory challenges. So I think we should focus, not focus, but I think for me, the most challenging populations are infants and premature babies.
Agree. Thank you. Thank you so much. Now, Drs. Cosimo and Roberto, I have a few questions for you. How are the regulators strengthening pediatric pharmacovigilance policies? And are there any mandates for age-specific post-marketing surveillance?
Okay, maybe I can have a go and then Cosimo can complement. So at the moment, we treat every medication on its own. So if the medication has a pediatric indication, we would consider what are the risk minimization measures, for example, that are needed, or if the reaction that we are observing is specifically generated in pediatric patients, we will assess this in this population. At the moment, the approach, except for what Cosimo has presented, so in signal detection, the approach that we take is the same. And then, I mean, the pharmacovigilance is conducted in the same way. What is differs, for example, is like, for example, when something is authorized, for example, an antibiotic recently has been authorized from 3 months of age. Of course, we request that in the periodic safety update report, there is a special focus on safety, and this is not need to be done for 2 to 5 years. So, because we are conscious that, of course, the number of patients that have been recruited in that trial was relatively small, and maybe that antibiotic has a longer life. So this is only an example, but generally we tailor-made the recommendation for safety measures, either post-authorization safety studies or additional studies, to what is the evidence at the moment of the authorization and what are the characteristics of the medicine.
Thank you. Okay. How about what role can caregivers and patient communities play in enhancing pediatric safety reporting?
Cosimo?
Yeah, as I said, I think, I'll go for this. I think, quality of report plays an important role because we would try to be more as detailed as possible. Now we're talking about pediatrics, but for instance, in pregnancy, it would be trivia to have, information about the gestational period, for instance, and then you recognize patterns and so on and so forth. Equally, neonates, we have a very small window intervention when it comes to the younger age group, because of course, the outcome is much more severe most of the time. And I think what will help in general is that communication, and I see a text also in the chat, communication is also crucial, because we need to be able, hopefully with the help of electronic records and the big data, we need to be able to measure the risk and reassure, because sometimes, the fear is higher compared to the risk and the disease we are treating. So that is fundamental. And going forward, as I said, advanced technology, trying to screen as fast as possible literature, but also we are trying to use NLP, natural language process, to read quickly the narrative and give us a hint where we need to focus for valid cases. This will create, as I said, fast generation of evidence. But we need to validate such systems, so we need to see how they're going to help us in improving the quality of reporting as well.
Thank you. Let me check the chat box. Okay, you answered that one. Here's another one in the chat. How do differences in reporting requirements across countries affect risk traceability and share regional contexts?
That is a very good one. I might take that too as well, because of course there are reporting requirements, and we notice heterogeneity, we notice variability, and then you need to take into account when you're using a global database such as VGBase or such as our database, Vigilance. We try to focus now on subgroup analysis also at regional level, so that we can see that difference in frequency, difference, or the analysis are actually supported. For instance, we notice that there are certain events, they follow the regional trend, and they're not confirmed in all the regions. And we need to take that into account. And also, I would say that we actually, that is what, real world data will help us based on the drug utilization within a specific region, and the type of population will help later on to confirm the initial signals that are triggered through spontaneous reporting.
Right, I see. Okay. And regarding pediatric safety guidelines, can EMA allow external pharmacovigilance experts to be part of the public review and then provide the feedback?
Yeah, so basically, as I said, the good pharmacovigilance practice for the pediatric population was agreed a few years ago. Now we have matured considerable experience, I would say, But the experience that we have matured does not really nowadays point out to a different way to conduct pharmacovigilance for adults, between adults and pediatric patients, although there is a need to do a thorough review. We are currently conducting such review, and in the future, probably the GVP would, so the guideline would need updating, and generally when the time comes, we either organize a workshop to gain consensus also with the opinion leader, but in any case, at the very minimum, the guideline is released for public consultation, and at least then all the organizations that we deal with, patients organization, healthcare professional organization, are generally sent a reminder of the guidelines that are under consultation, for which we include comments. If I can, maybe one of the aspects to be taken into account is not only the conduct of the pharmacovigilance, but is the impact of the risk minimization that we put there. So once we recommend the communication, is it impacting adults and adolescents in the same way, for example, for medicines that they use? Or if we restrict the marketing authorization of a medicine, or worse, we withdraw from the market, what's going to happen for a pediatric population if there are lesser alternatives that are authorized compared to adults? On this particularly, I think we need further experience and further consideration. Thank you.
Great, thank you so much. Okay, Dr. Siva, welcome. From your perspective as a physician and safety expert, what unique challenges exist in detecting and managing adverse drug reactions in children compared to adults?
Firstly, thanks a lot for inviting me to speak on this, and wonderful presentations by all the speakers that spoke before the panel. A great question again, right? I think there are multiple challenges because children are not to be treated as small adults. Some of the unique challenges that are there are basically the physiology, the developmental pharmacology are completely different. They see a rapid changes in the ADME, which is the absorption, distribution, metabolism, and excretion across the neonates to the infants, to toddlers, to adults, which means that the risk windows as well as the dose-response relationships vary. And the other challenge is also because the pediatric population dosing errors, right? Because we have to provide them calculations of the doses required based on the weight as well as the age. So that itself is a unique challenge. But at the same time, as in one of the presenters that I also presented, right? So there are underreporting, there is reporting bias. We do not have a lot of denominators, especially for the rare events. Definitely the formulation risks itself is a change. It's a challenge when we compare it with the adult population.
Thank you. Next question for you, Dr. Siva. This is regarding technology, which is transforming healthcare. What role do you see AI or digital tools playing in improving pediatric safety, especially in adverse event reporting and data interpretation?
Well, again, there are multiple frameworks to include pediatric populations in the trials and the pediatric investigation plans and all of them, but still there is a requirement in the industry that you can leverage some of the HRs, the RWD data to even identify some of these early signals, right? So we can also have self-control case studies, which is very well proven in the vaccine, but we can also evaluate the same in this area. But at the same time, I think there needs to be a smart dosing calculators that we most of the times have handy in the hospitals, right? The variables, some of the reporting apps for the caregivers is also a very, very crucial technology that we need to leverage, especially in the pediatric practice.
Thank you. In your experience, what kind of collaboration between pediatricians, caregivers, and safety professionals can make the most impact on child safety, especially in low resource or overburdened healthcare settings?
Well, I think that's a great question because we work in a SIG, which is very much doing the focus of having the SIG is definitely this, right? How do we really bring in all the collaborators, the pediatricians, the caregivers, and as well as ourselves, the safety professionals, right? I think there are multiple ways in which we can really low, lower down the burden from these low resource settings. One is definitely to see how do we train the community health workers and make them more engaging to this, right? On some of the areas, data capturing, how do they have to escalate things to the clinicians at right time, right? And also build certain forms which are, very much bilingual sometimes, most of the time, because caregivers have the ability to read and write as well. So that gives them a lot of leverage. At the same time, I think how do we really embed the safety into routine child health contacts is an important aspect. And this we have been seeing in the immunization visits, the growth monitoring when we have a pediatric case in the OPDs, right? We can also look into follow-ups, right? I think joint education from both caregivers as well as clinicians is very, very important. But having implementing all of these, we need to also have certain feedback loops, right? Where they acknowledge the caregivers report, they can acknowledge and also have simple guidance. When the clinicians report, safety teams should provide that case level feedback. And that's a collaboration, right, to even enhance this. But from a low-tech digital enablement, we need to see how can we use some of the applications that are there in the mobile, right? WhatsApp groups, right, or the Twitter groups, right? I think these are some of the things that we can definitely leverage at least in the low resource setting setup to increase that collaboration between all these different parties. But as I said, children are not small adults. Detecting, managing these pediatric ADRs require a tailored epidemiology as well as very much child-centric data capture. They very much require those safety checks. The caregivers play a very important role in this, right? And definitely artificial intelligence and the tools that are available are readily in our hands, tip of our hands, are very, very crucial to even provide that support.
Thank you. You brought up an important point. This is why we have pharmacovigilance in the community is, we got to teach, train healthcare providers and not just the healthcare providers, but also, the patients, including the caregivers. Excellent. Thank you. And one final question. This is addressed to all of you. What is one actionable item each stakeholder can do this year to ensure safer care for children?
Maybe I can start on that because Rebecca, I think you mentioned it just now. So we all understand how busy healthcare professionals are, but nevertheless, I think raise further awareness for about the reporting tools for patients and caregivers is very important. I can specify that it's basically the most important thing to raise the amount of reporting. Then I think from the regulators' perspective, I think also Siva touched on it a little bit, that it will be great to see not just collection of data, but maybe collaboration and maybe sharing of this data so that we can see all this data together from clinical trials, I don't know, from registries, from hospitals, you name it. And then if I'm thinking from perspective of the industry employees, I would say that I've seen quite a few pediatric so PEEP programs, which is quite reassuring. And yeah, I think my message would be just to kind of not just collect the data, but make sure it's detailed, it's full, and it's connected and usable.
Right.
No, I think I completely echo the thoughts of Elena. And the other aspect is the pediatric population's over reliance on adults make them more vulnerable, right? And as a caregiver or as a parent, right, we need to ensure that we report any unusual change in behavior, or maybe appetite sometimes, or sometimes sleep as well. So these things most of the times are not considered to be very serious, but I think we need to ensure that these are looked from a broader lens. Even if we are unsure if it is drug related or not, right? Because children might not be in a state of expressing their symptoms very accurately. And I would say the best pediatrician is the mother or a caregiver or a parent at home who can really understand and correlate between those unusual changes with what has happened.
Yeah, everything matters. Even the little input might go a long way. That's true.
Correct.
100%. Great. Anything, Dr. Cosimo and Roberto, you would like to add?
Yeah, actionable item, I would say something that is pretty obvious and quite simple. For the prescribers, please read accurately the summary of the product characteristics that is available online, fetch it, print a copy, save a PDF copy on your mobile, and read at the very least the safety part and the warning side and the contraindication as well, the drug interaction. And for patients also, you know, there are patients leaflet. Every time a new medicine is taken, please read it carefully. I'm not talking about paracetamol clearly, but I'm talking about the crizotinib, you know, blinatumomab. These are all new pathways, new medicines that are completely, in a way, that are new for the pediatric population, and are also new sometimes for the pediatrician that would not necessarily have been familiar with them. So yeah, get familiar, know the safety profile, so in a way that you can detect what is unexpected. Sorry, Cosimo, you were meant to.
Oh, no, I think you nailed it, because that is very important. We put a lot of effort, a lot of work into try to minimize the risk. We would like not only to recognize, identify new risks, but we would like to diagnose them as fast as possible, manage them as good as possible, and also, of course, prevent them. And I would also add to Alina's comment, which I fully support. We need data. We need also quality, as I mentioned a few times. We are coming into the era of pharmacogenomics, and so we can really make a difference if we try to characterize the risk as much as possible in line with the target population. Thank you.
Excellent. Thank you. Maxine, you have a question?
Yes, thank you, Rebecca. I enjoyed all the presentations. I really learned a lot as a basic pharmacologist. I really enjoyed the presentations. I liked one of the slides that a comment about off-label use and balancing with benefits versus risk. And I think that's a very important point to keep highlighting, especially with all of what's happening with this push for pediatric population in clinical trials. I just see the price of drugs moving up even more for our low and middle income countries. So my comment to you, I just wondered, where is SIAMS in all of this? If any of you know, if they are, looking at some working group, to give some standard operating procedures with all of this push of the importance as it relates to managing the safety risks that we are engaged in right now with drugs and pediatric population.
No, I'm not particularly aware of any initiatives in this sense. Thank you.
Okay.
Me either.
So is it that SIAMS is fast asleep? Usually they would have a working group moving along to provide some guidance to us. We depend on their guidance quite a bit. Okay, that's it for me, Rebecca. I guess I will have to probe some more in terms of SIOMs where they are.
That's a great point. Yes, definitely. I'm looking in the chat box. I don't see any new questions unless Saira, any questions that we're not aware of? Okay. No. Well, thank you so much. It was excellent. I learned a lot. I'm always learning. Thank you so much for your time. I know all of you guys are busy, so we greatly appreciate it.
Thank you very much.
Thank you very much. Thank you.
Thank you all for your attention.
Thanks.
Thank you.
Thank
Thanks,
you.
bye.
Thank you very much. Bye.